Good afternoon and welcome to this episode of CDA Oasis Live. I'm delighted to welcome back today a great friend, Dr. Sonny Virdi from Winnipeg, Manitoba, GP. And Sonny is passionate about restorative dentistry. And Sonny, we're going to talk about a challenge that everybody who's ever filled a tooth has faced. Class 2 restoration, deep cervical margin. I guess it even keeps you awake at night, does it?
Oh, totally, John. This is, I think, the bane of our existence as restorative dentists when we have to deal with these deep interproximal cervical margins. It can be a nightmare. And I've developed a few tricks, or not developed, but incorporated a few tricks into my practice that help me with them. And now the other dentists I work with refer their deep interproximal lesions to me now. And so whether that's a good thing or not, I don't know. But I have a few tricks to share with people so we can help manage them a little bit better.
Be careful what you wish for, okay? So exactly. I think you want to show us a few images and you'll walk through some of the major challenges and what you do to deal with those challenges.
Yeah, totally. I'm just going to share my screen here and we'll go through a case together and talk about some of the surrounding issues of deep cervical margins here.
All right.
So I'm going to share my screen. Can you see my screen there, John?
That's right. And you're still not in the slideshow mode. And we're seeing notes, yeah, so it's just a little adjustment to get it to there we go. The floor is yours.
How's that?
Perfect.
Good?
Yeah.
Awesome. So like margins. And this is it can be a pretty stressful thing. And it's funny because to a patient, it's just like a routine filling, like you're just doing a filling and they don't know how much probably we're sweating when we see this. So I'm going to go over some tips on how we can manage that. So, I prepared a little typodont to kind of show us, go through this because getting photos of this clinically is very difficult. Getting a light down there when it's deep, subgingival with the rubber dam on, it's not easy. So I did this on a typodont. But the first thing I want to talk about before we do anything is that we have to remember materials have their limits. So for direct restorations, I use composite like 99% of the time. But even with composite, we have to remember that there's limits. And sometimes we push those limits because we get so comfortable with the material. Like I know it works well in my hands, but I have to remember that there's limits to there. So when we have deep interproximal decay, I think it's important to take a step back sometimes and assess whether composite, or whatever direct restorative material you're going to use is a good choice or not. And the first thing I look at, and the most important aspect for me, is whether or not we have that sliver of enamel in the cervical box. If you know you're going to have some enamel at the base of your box, I think a direct restoration is going to work well, especially composite. It works amazing when you have enamel everywhere.
Right.
But when it goes past that, I think we have to start having conversations with people about using an indirect approach, even though it might just be a simple MO or DO. This is where I think we've lost our way a little bit with, not doing as much gold inlays and onlays. Like I think that in those cases, when we lose the enamel at the base of our box, an indirect approach with still a conservative material like gold, I mean, it can be an amazing way of treating the lesion for the patient in a long-standing way, because we can fill that hole with anything. That's easy, but we also want longevity, which we have to keep in mind as restorative dentists. So we have a deep cavity here. So, what is our first thing that we do? We put a Tafelmeyer on, and this is what we see. We see this space here. Yes. And then you start to see, based on your isolation, is blood coming through? Is the gingiva coming through? It's really hard to seal this area, and it definitely gets frustrating. And maybe you're trying on like the extended band, or you're trying on different matrices to try to get a seal, but I know that sometimes you just don't get that seal. and you just kind of move on and you restore the tooth and you tell the patient, look, it didn't go the way we planned, and we need to keep an eye or watch it, and maybe we need to do, you know, crown lengthening and a crown, and you know, and maybe that is the right approach. But in this specific scenario, we're now doing a direct, you know, we're stuck with what we've chosen, so we got to get it done. So my approach is a little bit different here. So okay, let's say the Toffelmeyer is on here and we have this opening. What I like to do is I take a little band, a sectional matrix,
Right.
and I trim it. I cut the edges off to make it a little bit smaller. And the reason for that is what I'm going to do here is place it inside that matrix.
Oh.
And so this is called matrix and matrix technique. I didn't invent it. I just adopted it into my practice. And this works fantastic for sealing that lesion. And there's two things. So the Toffelmeyer gives it, you know, kind of the basic shape and a retainer to stay in. And the little band now has like a scaffold to build upon and just close that, because a wedge is not going to close that, and you're not going to get a total seal. But you can see clearly, like if we look 2 photos ago, that's how it looked.
Right.
And all we did was insert this sectional matrix, totally sealed.
And so how do you ensure this seal at the bottom of the box there?
So typically just the physical pressure of having the 2 matrices is enough. Plus I have rubber dam down there, you know, to type it on. So that's going to give you some pressure as well. Right. The other thing you can do is you can take Teflon tape, pack it into a little ball and pack it in between these 2 layers, and you'll get it right down there. Because you won't be able to use a wedge here. Like if a wedge were to able to seal this, and I mean, we see this, right? These concavities and roots, and that's why I prepared it like that. They're not always sealable with wedges. So you can pack Teflon tape in between here and get a really nice seal.
Right.
The other thing I did is I showed that this is, you know, there's 2 class 2s here. There's one that's, you know, a straightforward one, and one's deeper. So always restore this deeper one first, because it's really difficult to get a contact when you have this stuff on there. Like you are going to get an open contact for sure. So you always restore this bigger one first. And I'll show you guys a little case that I did here with this. So when you look at this bite wing, you get that feeling. You're like, oh man, how are we going to manage this? And this is an elderly patient, you know, root caries, teeth are bombed out, and they're pretty medically compromised. So sure, you could say, well, are these teeth going to last? Maybe we should think about extractions. But, you know, in an elderly patient, sometimes they want to say, well, I want to do everything I can to save my teeth.
Yes.
I would love to do this in a, you know, an indirect approach with crown lengthening and treat this in an interdisciplinary way, but that just wasn't in the cards for the patient. And I think that's the reality for some of us. We have patients that we can't always manage with a super complex treatment plan. We have to make it work and get it whatever time we can out of the case. So this is when I opened it up. That's what you see. And that's when you start to think like, oh man.
Deep. Yes.
Yeah. What are we going to do here? And so the other tip I'll give you is that, you know, typically when we're doing these, I do a little laser gingivectomy here.
Yes.
To expose some of the margin there. And that's just so that the rubber dam can sit better. Because if there's too much tissue here, the rubber dam won't sit. And you can see I even tore my dam here. So after I do a gingivectomy, I put a new rubber dam on. Yeah. The other thing that you can do, if you were smart enough to think about before you started, was if you can stretch. Normally you floss in between each tooth, but if you take this hole and stretch it over that tooth, so there's two holes that'll be around here now. Right. You have an opening here, you do your gingivectomy, you're done, and then you just lift up this ring and put it back over. Yeah. That's one way to manage it without, you know, doing that. Sometimes I get lazy and I just want to start the case.
That's very clever, Sonny.
Yeah, and then we just start working, but that's a way that you can do it. If you want to save time too. Right. So, you know, I wish I had more photos. Like I said, when I start to see this, it gets hairy and I can't always take photos of every step. But I put the Toffelmeyer on, I put my matrix and matrix here, and, you know, pictures can be photoshopped, things can, you know, men lie, women lie, but I said radiographs don't lie. Nice. So there's our seal there. So very nice. You can see a really nice, you know, closed at the cervical area. Even I used the same thing on this premolar here, and we did endo there. So, you know, the longevity, of course, is the question, and will it last? Only time will tell. I think that we definitely push the limits of what composite can do here. But that, again, that's the reality for some patients, and he knows that, and we set that expectation.
Yeah.
Two things you'll note on this X-ray. There's a little line here.
Yes.
So what that is what I first did, because I talked about you can't really get a good contact with matrix and matrix. So I did matrix and matrix just to restore this part.
Right.
And then I took that off. Things are still dry because I have good isolation. And then I put a new sectional matrix just for this part here. So sometimes you'll have a little, maybe this is a layer of bond in here. I couldn't detect anything clinically, but that's why you see that little line there, is because I used a two-step approach. So that's how you can get a good contact when you have these problems.
Rightio, rightio.
And that's my tip for the day for dealing with the deep cervical lesions.
So let me ask you a real quick one then. You wished at the beginning that there'd be enamel all around, especially in the deepest part of the box. Let's say there isn't enamel all the way around. Do you ever use any sort of a sandwich technique or anything like that too? Or
I personally don't. I worry about the washout with glass ionomer over time.
Yeah.
But I know some people who do the open sandwich and then the closed sandwich, and then there's the super sandwich technique, and so there's different ways to manage it. But sorry,
that's your partner asking you to go and do another deep cleanse too, right?
Do a deep lesion here for him. But no, I personally don't do any sandwich techniques. I just stick with regular flowable and packable composite, and but I try to limit where I use these. I would way rather approach this in an indirect approach with a zirconia, Emax, or my preference would be gold, but not everybody likes gold.
Righty-ho. Well, Sonny, you were always great for the tip of the day or a couple of tips of the day. I hope you'll come back, and there's plenty of challenges in everyday restorative dentistry. So we love having you. So I hope you'll come back again.
Thanks, John. It's always a pleasure. We'll be back with another tip soon.
Perfect. Thank you so much.